So I want to welcome everyone to Rover 2.0 for residents. Today we will have the CNS panel. Go to the next slide. So we'll have each of the panelists introduce themselves. We can start with Dr. Hattengadi-Gluth.
Everyone, I'm Jonah Hattengadi-Gluth from UC San Diego.
Hi everyone, this is Sean Sachdev from Northwestern.
And I'm Jerry Jaboyne from OHSU.
Wonderful. So we have 3 cases today, and the first case will be presented by Dr. Jaboyne. So we'll hand it over to him.
Okay, let's jump in here. So we have a 75-year-old female presenting with 6 months of progressive decline in short-term memory and speech fluency. So focus physical, she's alert and oriented ×3 following directions. She has an expressive aphasia with frequent pauses, word finding difficulty, somatic paraphrases. She opens her eyes spontaneously, 5 out of 5 strength throughout, and her gait is stable, no drift. And I think I've got this as a little video. All right. Let me just make sure that I don't have the wrong type of question next regarding the imaging. I don't think I do. Can you go to the next slide and I'll just take a step back. Okay, yeah, so we can go back one. Go forward one, my apologies. All right, great. So you have a T1 post-SCAD image on the left. You got a T2 image in the right lower quadrant. So a relatively homogeneous extraaxial mass, well demarcated. And you can see that there's some vasogenic edema surrounding it. So we can go to the next slide. So what's your differential diagnosis? What's your next step in diagnostic evaluation? And oh, you can go back. I'm sorry. I thought there was a poll question for that one. I apologize.
No, but maybe it's a good point for discussion of what you all think.
Yeah, this is a really interesting case. I think, you know, Jerry, I'd be interested in your thoughts kind of when you see a patient like this, and Sean as well. You know, one thing is to look at, you know, she's 75, to look whether she, you know, had any other MRIs previously in her lifetime, or whether this is her first. And then sometimes, you know, we kind of want to get an idea of how fast it's growing if you don't have any priors. So the fact that there's some T2 edema, quite a bit of mass effect, but that there's quite a bit of edema may indicate that this was, you know, growing quickly or growing more quickly than a typical benign slow growing tumor.
I agree with all of those points. You know, if you can try to find any prior imaging, that's very helpful. You establish some growth metrics, get the added value, the variable of temporality. The other thing I would add is that, you know, just on imaging, it appears to be an extraaxial lesion. So that kind of narrows things down a little bit.
Perfect. And yeah, for her, I believe that she has something remote non-con CT, but nothing recent, and it should be managed more for her dementia or potential dementia. So what would be your next step in evaluation?
So one quick point about the non-con CT, sometimes it's helpful to see if there are any calcifications in the mass. Sometimes you can see that with a meningioma. And something that large, you probably would be able to see on a non-contrast CT.
Yeah, and again, hers was so remote that we couldn't note a mass at all.
And then beyond that, you've got something that, is extraaxial, as was mentioned previously, appears to have some mass effect. There's some surrounding vasogenic edema. This is something that if you can safely and easily get out, at least just to get tissue, but ideally to debulk, would be the good next step.
Okay, great. So good, next slide. So they went for a resection. Microsurgical gross total resection of that left-sided frontal contrast enhancing dural-based tumor. They did some internal debulking, so intraoperatively, circumferential dissection carefully, resection of dural attachment was performed, and no abdominal bone was noted at the time of resection, so no additional bone was taken. So I want to start with this as a poll question. What's the Simpson grading of extent of resection?
While you guys are all answering that question, you can also put any questions you have into the chat. A reminder to put to all panelists and attendees so everyone can see the questions. Can you see the? Yeah, I shared them. So 54% said Simpson grade 1, 21% Simpson grade 2, 14% Simpson grade 3, and 11% Simpson grade 4.
Great. So, with Simpson grading, this is for many institutions pretty important, but also very difficult to attribute because it all depends on what the neurosurgeon sees and how they feel about the extent of resection. So I see my partners here nodding. We've had these feelings where someone comes in, they say they got it all, but when they're a little bit more circumspect, they said, but it was a little sticky and I kind of peeled it off this, or I did some cautery, but I didn't necessarily resect any bone. So I would call the surgeon call this a 1. I'd call it at least a 1 or 2, likely. But we did call it a gross total resection, and I think it's good to keep in mind that you have to be able to note if there's any abnormal bone, remove that, et cetera, to really have a complete resection. In this case, the surgeon felt confident that there was some, that everything was removed, that anything that was adhering was removed aggressively, and actually did not proceed with any bovie cautery. So there was no nodular thickening that they needed to do bovie on. All right. Any additional comments from Jonah or Sean? Okay, it's a sticky area, so to speak. So pathology. So you had spindled ovoid cells with focal whorling and a fibrocollagenous background, and they had 5 mitoses per 10 high-powered fields. So by that definition, it's a grade 2 atypical tumor. The grading of meningiomas is pretty much the major change over the last 2 decades, 2000, 2007, and more recently in 2016. And that's given us a better sense of what's associated with risk of recurrence. But it's also the most sticky part of the treatment paradigm. So how would you plan treatment from here? So, next slide. So great. So atypical meningiomas are classified based on greater than or equal to 5 mitoses per 10 high-powered fields and brain invasion. But there are some histological tumors that automatically fall within the category of WHO grade 2. Which of the following would fall, one or more of the following would fall into this category?
waiting for the panel, for the attendees to respond, I thought we could just, I think this is a really interesting case, Jerry. I want to hear your thoughts and Sean's thoughts as well about like your tumor board discussion. I tend to find here at UCSD, you know, you can meet an criteria for an atypical by WHO guidelines many different ways. So your case, you've got five mitoses per high powered field. You could also have brain invasion and 19 mitoses per high powered field and like multiple other high risk factors versus within the WHO criteria and still be an atypical. So I kind of think about it in the way we think about like intermediate risk prostate cancer, you know, how there's like, you can still be intermediate risk, but then there's like these, you know, paradigms, there's like sort of a spectra within. And so I'd be curious to hear how you approach that within sort of whether you think about risk stratifying among atypical meningiomas.
And we do too. I'll let Sean go first.
Yeah, no, I was going to say I would echo all of your comments. You know, you can have a very histologically bland grade 2 meningioma that just has a little bit of focal brain invasion. And I'm not sure what to do, you know, if we should be treating those patients the same way that we would for the patient that you mentioned, Jonah, with 19 out of 20, you know, mitoses, other adverse histologic features for the WHO criteria. And I think there is a spectrum. And I think, you know, recently there was although we can discuss more as we go on with the case as to how we would manage this, but, you know, there's some data to suggest that maybe patients who have, you know, are grade 2 per the WHO, but if the, you know, if the Ki-67 or the MIB is low, or if they're otherwise histologically bland, maybe you don't need to treat as aggressively in an adjuvant fashion.
Right. And I say one additional feature of conversation for us is resectability or re-resectability. So in an area of eloquence or in the skull base where a re-resection will be very difficult, being a little bit more aggressive with those tumors, despite the, you know, the lower risk feature might be enough to warrant a more aggressive adjuvant therapy, knowing that you wouldn't have to go back. Whereas something that's kind of low intermediate risk in the frontal lobe or temporal lobe, you might be willing to observe. So in this case, so the first three, angiomatous, chordoid, and clear cell, are all grade 2 at minimum. They could be grade 3 if they have histologic features that would increase them. Meningothelial is typically a benign grade 1 category tumor. Have my lunch reminder here in the middle of my screen. That's the next slide. So if you were to do radiation, I've highlighted some current trials and recently completed trials looking at this cohort. So she's a WHO2 meningioma. As we said, there's different kinds of WHO2 meningioma, and there's been 2 clinical trials that have been performed previously and 2 currently enrolling trials. And actually, I'd love to get the perspective of Jonah and Sean on this. The standards around these trials there's a lot of allowance, right, for you to have different margin status, et cetera. I've listed them here: 54 gray and 30 fractions for RTG-0539. Some have pushed the dose a bit, 60 gray and 30 fractions for patients undergoing gross total resection that are WHO2. And some have tried to dose accelerate, especially for the WHO3. I'm curious as to what you do in your institutions.
I probably, you know, going back and thinking of the 0539 dose expansion recommendations, I think I personally find them to be a little bit more on the too generous side. So for these patients, if we're treating adjuvantly, I will define the cavity and then I will basically do a dural margin. There's some older data from Emory that seem to suggest that, you know, with all the expansions, even if they're less than a cm, you know, you're not really sacrificing tumor control. So for me, I'm typically using, you know, a 6 degree couch correction. I'm using fancy daily IGRT. I'm beyond the resection cavity, dural margin, and then a margin on that to about 60 gray. That's generally my approach.
Yeah, I mean, I think a couple points here, just going back to, I think, you know, I mean, this is kind of an interesting case. I think subtotally resected grade 2, you'd obviously want to treat. I think a GTR with a high Simpson, Simpson 1 or 2 resection, I think the data is kind of mixed about doing radiation or not. I think one point I would like to make is, the way I approach this is really trying to go beyond just a grade 2, which is kind of how these studies really, looked at patients, kind of lumping them all together. So one other point, there's some interesting data in meningioma looking at DNA methylation patterns. It's not always available, but it's a very common thing at NYU. There's a neuropathologist there, Matthias Schnuderl, who does that. And that's actually been shown, the DNA methylation status has actually been shown to be highly correlated with risk of recurrence. And the other thing that you could potentially get is like an oncoscan, which we do at our institution, which is looking at chromosomal abnormalities, which are associated sometimes with those DNA methylation patterns and recurrence risk. So I would like to first sort of risk stratify this lady because she's 75 in terms of her adjuvant, kind of risk of recurrence, to talk about either doing, adjuvant radiation or kind of following her. In terms of the margins I use, I'm probably pretty similar to what Sean used. I think something I really go over with my residents as well is just, it's not a uniform expansion. It's very focused, it's an expansion along meningeal boundaries and dural boundaries, like Sean was saying. So you're not going to expand it right into the brainstem or into tissue, because if there's no brain invasion, that's not really how meningiomas grow, right? They're going to grow along the meningeal surfaces. In some ways, I actually think this is kind of one of the more interesting CTVs to draw in CNS, because it's not just a uniform, expansion.
And I agree with everything that you said. We have a great neuropathologist here at OHC who's come from UCSF, and we're working with Ari Perry, who's primarily involved in both of these reclassifications. Actually, he did it even as a fellow at Mayo for the 1999 WHO alteration, but it's kind of nice to have now these better gene trails to look at DNA methylation patterns as well. He has actually a nano array for that analysis too, just to give us a better sense of risk stratification. For our institution, it still tends to be more about the location. Although, when they get back to our office and we start to have these conversations, I tend to first always offer a clinical trial when it's possible. And so we do have the energy trial to enroll on. Finally, it's taken us a while to get there. But for many of these patients that are like her, I will tend to look at these other features, just complete resection, able to get everything out with a low mitotic index and go from there. She was this is about a year and a half ago, 2 years ago. So she's before we had all these nice fancy tools to do the assessments, but completely agreed. In terms of margins, also agreed. We try to make sure that the parenchymal margin is really just a PTV, but the rest of the extension is along the margin. So it does make it a more interesting and makes you feel a little bit more creative in delineating these margins.
Add a quick point to what you were saying, Jerry. I'm sorry, I didn't mean to interrupt you.
Oh, no problem.
We also have BN003 open here. I've enrolled 3 patients on it, but we try to get everyone who's interested on the trial. The people I hesitated about are the ones who are just histologically showing some very aggressive features, because I wonder if they get randomized to the observation arm, and if they have a radiographic recurrence, then we know that in that scenario, basically what I described, the 60 gray and the expansion pattern I described was for, gross totally resected grade 2 meningioma. If you have a radiographic recurrence, we know from the high risk cohorts of 0539 that those people don't do very well with EBRT. So, right. But I think BN003, from my understanding, is accruing per the projected, path. So hopefully that'll add some very important information ahead.
Very good. Very good. Let's see. I don't remember how much more I have here. I think we're a little bit beyond the 15 minutes. So challenging aspects of the case. We discussed quite a few here. This is great dialogue, and it's good to have people from different institutions because this is a very heterogeneous approach to this type of tumor. One additional challenging aspect is optimal recovery time. So say you do have that patient with the very aggressive histopathology, how long can you wait before initiation of treatment? I don't know if the panelists have kind of their outlier times.
Yeah, I would tend to wait the sort of standard, like for, like 4 to 6 weeks, I suppose. I mean, this patient was elderly, had a lot of mass effect, whether she had some post-op complications. I think if it was a, high risk, grade 3 meningioma, if there was considerable residual disease, you may want to kind of expedite treatment. And that actually brings up, it looks like Dr. Palm had a question. In cases of subtotal resection, do you dose escalate beyond 60 gray off trial? Know what you guys think about that?
Yes, I try to think outside of the box for those kinds of cases because I know I'm not going to get good long-term control with just 60 gray. So when I can safely, I will do some form of SIB dose escalation. In the past, I've also tried just doing a larger field to 45 to or 50, and then doing a radiosurgery boost to the contrast enhancing disease. But I think that's a really kind of a interesting scenario for which we don't have perfectly validated answers, but clearly we need to do more than what we've been doing historically.
Agreed.
Yeah, I think that's a good point about the, sorry to interrupt you, Jerry. I was just saying to piggyback off what Sean just said, the SIB tends to be really nice, especially I think if you wanted to, cover that dural margin, which tends to be quite large post-op at a lower dose, but then that residual disease, give higher doses to like 66 to 70 gray or something like that. What we do, especially for a grade 3.
Yeah.
Dr. Sajdev, there's a question in the chat also, since you've enrolled patients on the 003, about how you discuss that with patients, considering observation as one of the options.
Yes, that is a good question. And that is, this is a trial that's hard to accrue to because logically, and especially during the COVID era within this past year, it's been very hard for me to accrue to this trial because if you present to a patient that we have equipoise and that we have these two options that you can be randomized to, then of course the next logical question is, well, if I can be randomized to the observation arm and you're okay with it, well, why don't I just pursue observation? The way that I approach this question with patients is I present our data. So we have published on we had a paper in Cancer 2 years ago looking, it was an NCDB analysis where we looked at overall survival. Granted, I know a lot of us have lost our appetite for more NCDB papers, but it showed a clear, improvement in terms of overall survival. We didn't have very good data on lesional control, but basically the group that did the best for the NCDB was the group that got a gross total resection plus adjuvant RT. And there was another, I think maybe from OHSU or paper there's a paper that was published within a few months in neuro-oncology that also showed a benefit in overall survival. And from other lower quality data, what I tell patients is that, I would recommend off trial adjuvant radiation it would be my recommendation. If you don't want to be treated, then this is a great way for you to get at least a 50% chance of being followed closely in a very protocoled fashion from an NCI, sponsored or basically NCI administered trial. And so that's when people think, all right, well, maybe I'll go on the trial, basically.
So I concur. I love it. And I use the same 2 trials, by the way. Next case.
Yeah, that was wonderful discussion. We'll move on to case 2.
Okay, great. We can go to the next slide. So this is a patient, a 27-year-old right-handed gentleman. He presented with 6 weeks of worsening headaches and some trouble, at work. He's a software programmer. He had some nausea too. And on exam was alert oriented, and other than being anxious, had essentially a completely normal neurologic exam. On MRI, on the T1 post-contrast imaging, had a right frontal enhancing mass, and on T2 flare, there was a bulky T2 hyperintensity associated with that mass with some surrounding edematous changes extending into the left frontal area. So I don't have those images for you because this was an outside image, outside hospital. You can go to the next slide. So he underwent at an outside hospital craniotomy and a subtotal resection. The pathology showed an anaplastic astrocytoma. It was 1p19q non-codeleted. They did immunohistochemistry for the R132H probe for IDH mutation, and that was negative. But they did have the foresight to send it for next generation sequencing, which revealed an IDH2 mutation. It was also shown to be have a P53 mutation and ATRX mutation, as well as EGFR amplification. And you can see kind of the histopathology there. So I think, one point I want to ask the other panelists is, I think it's very common. I treat patients who are also, worked up in the community to sort of do the immunohistochemistry for the IDH mutation alone, and then sort of send off to adjuvant treatment and not get that NGS. And I think this kind of shows what the value is of really exploring whether a patient has an IDH mutation or not, which is that, with that IHC R132H, you're only really going to capture 90% of IDH mutations, and those remaining 10% could be ones that you'll only get on next generation sequencing.
That's a really important point, and especially for all the residents who are on, oftentimes I'll hear a patient presented as being IDH wild type, but it's important to be more specific and say that, IDH wild type per immunohistochemical staining of R132H, which is the most common mutation, but I have also treated patients who have other IDH mutations. I've had a patient with R132G. So I think that's a really, really important point. You can't just do that stain and declare that a patient is IDH wild type.
Yeah, and I think one other thing you could, I think that's something when you see a patient in consult, for the residents who will be in practice soon, you can request that. It may not change your adjuvant treatment, but it is helpful to get that done, especially because that sequencing does take time. Okay, I think we can go to the next slide. So this is the first poll question. Among WHO grade 2 to 3 gliomas, what percentage will have mutations in IDH1 or 2? And this is all mutations, meaning if you did NGS on them, not just the IHC R132H. And Jerry, is that your practice too at OHSU to get NGS on all gliomas?
Absolutely. In fact, we hesitate to discuss it because it affects your imaging as well, right? Your positive predictive value on whether or not you see progression, right? Yeah. So it's crucial.
I think that's a great point. In fact, I saw recently a young man who had what looked like very much like an oligo, non-enhancing, but a very clear-cut sort of flare, hyper-intense mass, and he was IDH wild type with the IHC and was sent to me. We got NGS, and he did indeed have like it was IDH1, but some weird random different amino acid mutation. So it looks like the choices were 10 to 20%, 20 to 40, 50 to 90, and 100%. And the correct answer is 50 to 90%. So we tend to have, you'll see a different report and range like TCGA Atlas and things like that. Some people say 80%, but it's, the majority of grade 2 to 3 gliomas. Now, of course, this number will be much lower in primary GBM, more like 10% or lower. Okay, we can go to the next slide. So the patient was treated initially with adjuvant chemoradiation with temozolomide. You can see his post-op imaging here. So you can see the resection of that cavity on the left on the T1 post-contrast imaging, and on T2 flare, you can see there's some residual flare hyperintensity sort of in the periventricular area on the left, as well as posterior to the cavity on the right. So he was treated to 59.4 gray and 33 fractions with concurrent temozolomide, received a year of adjuvant temozolomide per sort of the standard guidelines, and was observed then with serial MRI for 4 years, went back to work, was living his normal life. Next slide, please. Or any thoughts about this actually? Would any of the panelists have treated him differently initially?
Yeah, just one point, and that's the dose. And I don't know what the right answer is here, but we've had a few recent debates among our group and across our system at Northwestern. There's some people who might argue that if you're dealing with an IDH mutated glioma, maybe as opposed to going to 59.4, 54 gray might be the right dose. That's how BN005 is actually written. Anyone with an IDH mutated glioma, the protocol specifies 54 gray. because perhaps, more important than the histopathologic grading between grade 2 and grade 3, the IDH mutation is more sort of prognostic as to how the patient will do. I personally don't know what the right answer is. If you look at a trial like CODAL, that would still specify that you go to 59.4. But there's room, I think, for debate there.
And at the time this patient was treated, also the question of whether or not to use temozolomide and for how long in the adjuvant fashion would have also been questions. I still have some colleagues that will only do PCV and will not do more than 6 months of TMZ. Our practice is pretty similar to this. But
for non-codeleted patients, they'll give PCV?
Say again?
For non-codeleted patients, they'll give PCV?
Yes, yeah.
Oh, really? Oh, wow, okay.
Yeah, and so more of a, I don't know if anybody from University of Washington is here, but that's been a practice for some time. And again, these are great and interesting discussions, the reasons why and why not, but.
We usually almost always go with TMZ. Roger Stoop is here, so that obviously kind of influences everyone else. But to Jonah's point, the time when a few of our neuro-oncologists will strongly push for PCV or just PC would be if they're oligo, if they're co-deleted molecularly oligo.
Right, that's our practice as well. I think, Sean, you brought up a really interesting point about the dose. I think in my practice, I have not dose de-escalated in this setting, but I think it's a really good point. And, currently it does reflect a more sort of molecularly guided dosing rather than, WHO grade, guided dosing. So we can move on to the next slide. So 4 years later, he's getting serial MRIs. So you can see the top series shows it's basically two episodes, two sets of images 6 months apart. So on the top, you can see from left to right, there's the T2 flare, post-contrast, and then DWI and ADC. And then what you see if sort of you compare from top to bottom on each section is that the flare hyperintensity on the left is sort of getting more bulky. The T1 post-contrast, you're starting to see these little nodular areas of enhancement within that bulky area. And then interestingly, you start to see more restricted diffusion. So DWI bright, ADC dark, meaning that potentially some higher risk of cellularity there. Next slide. So the question here, which is sort of for the panelists, is, what is our differential here and what would be your next step? So I'd like to hear, Sean and Jerry, what your thoughts are.
So this is 4 years out, right?
Correct.
So, this far out, even for an IDH mutated glioma, you might start to worry about true, a true tumor recurrence. Beyond that, I suppose some prolonged, distant treatment-related change, but I think that'd be less likely.
Yeah, agreed. And, cavernoma there's a lot of unusual vascular changes that can occur after some period of time, but at 4 years, recurrence would be highest on the differential.
Yeah, I think there's also, that's a good point. Yeah, I think, if we go to the next slide, we can talk about additional imaging tests. So you can click again. So it shows the flare. We tend to use at our institution some other imaging sequences. So perfusion. So as you can see on that DSC perfusion, the cerebral blood volume, if you look in that area that's the hyperperfused in that area of sort of that bulky flare hyperintensity. And then this patient also got MR spectroscopy, which can also be helpful to sort of discern between, radionecrosis or radiation treatment changes versus tumor recurrence. On MR SPECT, this spectra reflects a high choline and low NAA, which kind of reflects more true tumor progression rather than radiation changes. I can say, like at our institution, we actually have a perfusion incorporated into our glioma protocol. So we actually get perfusion. So it's not an additional sequence or an additional, billing code. For us, MR spectroscopy is, and so I tend to find that that's more challenging to get reimbursed, and I actually find that sometimes it can be messy. This case is kind of an ideal case that actually shows the nice spectra of what's consistent with a progression, but I'll be interested in what Sean and Jerry, what you do at your institutions.
Post radiation, we routinely actually also get perfusion and spectroscopy. The first post radiation scan is always done with perfusion, and then if there's any question ever of true tumor versus necrosis or pseudoprogression or other treatment-related change, we'll get both. Frankly, my own view is, which has largely been influenced by a few of the neuroradiologists that I've gotten to know here at Northwestern very well, and I trust their judgment. It's always a little helpful, but I would say personally, and maybe that's my own view, it rarely completely changes the management. I think it adds a little bit of information, but it's always never perfect in sort of guiding you one way or another. Oftentimes it's just radiographic appearance and, more importantly, how the patient's doing, which may dictate the next step, but certainly worthwhile to get the added information.
And it's a standard part of our protocol here at OHSU. We've added to our MRI brain tumor set, so it's part of our standard orders. But what we've also done is a lot of pheromoxetol imaging, and we find that that's been pretty compelling for looking at blood flow, and there might be some evidence that, or suggestion that you could get some early evidence of an enhanced cerebral blood flow using that technique, but we're pretty similar.
There's been a portion of our group that's been clamoring for and is eager to get into more PET-based imaging, but we don't do that routinely here yet at Northwestern.
Yeah, I mean, I think those are all great points. There's different imaging, sequences that can help discern. And to Sean's point, I think, for us, this patient was asymptomatic. So I think for us, you kind of want to, especially in terms of brain metastases as well, you want us to look at recurrence early, kind of before they become symptomatic. We use ASL perfusion, which is actually a little bit less noisy than DSC perfusion. And it doesn't involve any extra billing code or contrast. But so that's, I guess, one of the downsides of PET is that it's an additional, test for the patient, and getting the tracers, some of those radio labeled like, FD-DOPA tracers, I think may be harder to acquire. So all interesting points. Next slide. So on exam, he was doing fine, no neurologic deficits, still pretty high functioning, though with some of the same deficits in executive functioning he had. Oh, go back. Sorry, wasn't finished with that one yet. So, so he actually went on to have a stereotactic MRI guided biopsy with an intra-op MRI. And on pathology, shown to have a GBM, met the WHO criteria for glioblastoma, and GS showed that same IDH2 mutation. And the same molecular with the EGFR amplification, as well as high mutational burden. So wanted to get the thoughts of the panelists on, what is the next ideal step in management, and have the attendees vote too. So your options are, for this gentleman, you could do surgery, reirradiation, clinical trial, Optune, or immune checkpoint inhibitors. Maybe Sean and Jerry, while we're waiting, you can kind of tell us your thoughts on the next step for this case.
Yeah, I mean, I think, whenever you're dealing with a recurrent glioma post-standard treatment, as I often will start the discussion with patients who are being considered for reirradiation, I always make the point that there's no standard treatment. It always, these are the cases that we spend a lot of time discussing during our tumor boards. Generally, the preference here is if we can get them on a clinical trial. That's the best. That we always want to go down that road. But if something is largely focally recurrent, then reirradiation is always an option. And arguably, with the mutational burden, one could even consider something like checkpoint therapy.
Right, and so all true for us as well. We've used IDH inhibitors as well more recently. IDH2 mutants, there's some data that suggests that maybe they're a little bit less responsive, but all this data is nascent, and a lot of these drugs are brand new. But maximally safe resection is usually our first course of action.
This is a good, really good discussion. Kind of agree with the panelists too on what you'd recommend. I think NCCN guidelines, and I think everybody, the consensus is clinical trial first. It looks like 30% of our respondents voted for clinical trial first. If there was a clinical trial, this patient did not have a clinical trial option. Surgery, was another one. This patient actually ended up declining surgery. I think one of the issues was, which you couldn't see that well on that slice, is that the disease was actually kind of going into the corpus callosum. And so couldn't really have been completely resected anyway. And so, yeah, I agree completely with Sean and Jerry. I think that, our approach tends to be to evaluate a tumor board and kind of look at the molecular data and look at each option. Like, I think any of those, A to E, could be a potential option. Most of our patients actually tend to decline Optune in the recurrent setting or use it in conjunction with something else, not just really on its own.
I'd be curious, Sean, for what's your TTF usage with Stoop there?
It is offered to everyone. I'd say it's probably between 30 and 40% of patients treated up front. We have an IIT now, which is trying to do basically almost like a focus group kind of an assessment, trying to figure out how patients decide between Optune versus not. We're also opening the NovoCure sponsored trial Trident, which is basically which would allow Optune usage during radiation. But I think a fair bit of people will go for it. It's largely, from my experience, personality driven. There are those who say, "Give me every available option I want," and then there's some who have a more of a balanced view, and are deterred by the quality of life sort of issues, walking around with an electro cap for most of the day.
Jonah, how about you?
Yeah, I mean, I actually am surprised that we don't. I think it's really kind of how it's sold with anything. I think it's sort of like how it's pitched. And I think that, a lot of my patients will do it sort of in the adjuvant setting, given the, the upfront GBM data. But I find a lot of patients at progression tend to decline it. And it's similar to what Sean said, it's really personality driven, the quality of life burden of having to shave your head and where that's cap. One other quick point I wanted to make in terms of like the recurrence, what to piggyback on what Sean just said is that, that higher hypermutation, sort of paradigm, which we tend to see in post-temozolomide, can be an indicator that, you could give immune checkpoint inhibitors. So that's another potential avenue here. That's actually what we ended up doing for this patient. He ended up getting reirradiation along with immune checkpoint inhibitors. But kind of getting back to when we think about reirradiation, I think the data is still sort of mixed, as there's a lot of like retrospective, some small prospective data. There's different ways to do it. RTOG 1205 was presented by Dr. Tien at Astra last year. I don't believe I've seen the final publication, but it was a randomized trial of, as we know, 35 and 10 plus Bev versus Bev alone. And the primary endpoint was survival, which was a negative, no difference, but there was improved 6-month progression-free survival. And it was essentially overall well tolerated, but they didn't really go into a lot of the quality of life or any of the neurocognitive, data, at least in the abstract, in the presentation. There are other regimens sort of doing a more hypofractionated sort of stereotactic approach, like Memorial or the Henry Ford trial. And the things that I like to consider, kind of similar to what Sean and Jerry were saying, is really are there clinical trial options? Is there a way to combine this with something else? In this case, because of the hypermutation, we did combine it with immune checkpoint inhibitors. The time interval, how quickly did this patient fail? Is it in field or out of field? So I don't know if Sean or Jerry have any other thoughts.
I would agree with all of that. I don't have a very kind of a strict dosing algorithm in my mind. It's largely driven by, a time since the last course of radiation, how large the field would be. Shortly after the 1205 results were presented in our tumor board, there were a few people saying, well, this is the end of reirradiation, you didn't have an overall survival benefit. But then one could argue actually that we have nothing in the recurrent setting that has ever been shown to have an overall survival benefit. So I think when you continue to look at each recurrent case individually and, with a multidisciplinary input, there are patients where you have, very focally recurrent disease where I think reirradiation continues to hold a valuable role.
Yeah, I think that's a really good point. Jerry, what do you think?
Completely agreed. Each patient's individual, and for we know that we're not successful with a lot of these new drugs, partly because of the antigen presentation, but also having the excess number of clonogens. So lit therapy is also something we've discussed a bit too, as another way to do that, right? To increase antigen presentation, destroy clonogens while being able to maximize delivery of novel therapies. So each patient's unique, and it's worked. So
that's a great point. Yeah, and I think, Sean, I think the thoughts you bring up about, you know, reirradiation, I think people who do say 1205 is a negative trial because it was powered for overall survival, nor that almost everything does not have an overall survival in glioblastoma. And Optune actually also was just a progression-free survival and not an overall survival benefit in the recurrent setting. So challenging aspects, I think we went over the imaging parts and kind of evaluating all options and all data, trying to really push clinical trials, multidisciplinary review, and how really there's just so much more we need to do in this disease.
Okay, happy to get going with my case now, which is the last case of the hour. So if you want to advance the slide, please. This is a patient that I treated a few years ago, 64-year-old guy who presented with a few years history of progressive right-sided hearing loss, which ultimately led him to medical presentation and underwent a workup. Basically, otherwise fully neurologically intact. No headaches, vision issues, speech or hearing problems, strength or sensation deficits, no balance, gait, coordination issues, past medical history and past surgical history non-contributory. And on exam, largely neurologically intact, except for the hearing loss. The other cranial nerves grossly intact, no cerebellar signs, 5 out of 5 strength throughout, completely intact light touch in terms of sensation throughout, including facial sensation. And then, of course, as part of a comprehensive exam, no other features to suggest something of a head and neck cancer variety. Can advance the slide, please. So he was worked up with imaging as well as an audiogram, which we'll show next. But just here on the imaging, what we can see is on the left and the middle panel, you have a T1 weighted contrast enhanced image, and what we can see is you have an avidly enhancing contrast enhancing lesion arising from the right IAC and then going into the CPA. And then on the right, usually with skull-based imaging, different institutions use different vendors, but it's ideal to get a high-resolution T2 weighted scan. So here we have what's called the CIS, which is constructive interference steady state. But there, that's based off our Siemens scanners. But there are other vendors who have, I believe, Fiesta, and then there's a few other kind of names for high-resolution T2 weighted series. Those are all the kind of the notable findings that we see here. If you want to advance to the next slide. And then this is the patient's audiogram. And you can see right-sided hearing loss at higher frequencies. And then if we were to advance on to the next slide. So here's a poll question. So based on all that you've seen so far, what do we think this is? And at this point, I'm also happy to just pause and maybe I guess after the poll question has been answered, we'd love to hear thoughts of the other panelists.
I think there's a nice, like, classic ice cream cone, I think they call it.
Exactly.
You got the little cone and then your little ice cream ball of ice cream on top. I feel like it was a very classic case. Really nice images. Yeah, I think that, one thing to consider is the patient's, hearing preservation and kind of where they are in terms of their being risk averse to losing ipsilateral sided hearing or not. I tend to find some patients are like, I just want the safest option, and that's not really something that's, driving their decision making. And I also feel like it's also driven by how the patient presents and to whom. I know at our institution, we actually just recruited a very famous basic skull surgeon who used to be at the House Clinic in LA, who operates, I think he's done 1,000 acoustic neuroma surgeries in his career. So, I mean, they're very certain, they've always been very surgery driven. And so they tend to filter into radiation oncology if they're either non-operable patients or, too small or too tiny, or the patient just wants radiation.
These are all great observations. we have a variety of surgeons here. One from WashU is also very aggressive acoustic surgeon, but we developed a lot of techniques there that were a little bit multidisciplinary to discuss. Okay, when and where and how would you treat things? And I guess we can wait to see if everybody got the differential. Was the answer already flashed up?
Yeah, it'd be great to see the poll answers again, please, Nav, if you have access to the answers. So I'm glad to see that no one wanted to jump to get tissue right away. And basically, all of the above are valid options. And basically alluding to what Jonah and Jerry were referring to, a lot of this is driven by institutional practices and just the approach and who the surgeon is, who the referring providers are. I found that here at Northwestern, we've largely, and who knows what the reason for that is, most of our surgeons have actually gone away from treating these surgically. So I'd say the vast majority of our vestibular schwannomas are treated with radiosurgery. Maybe it's because of how the Gamma Knife platform is designed. They get to basically come down and place shots, and they feel like they're very involved, and so they feel that they can channel the patient through that approach. Usually the time that we're all sort of agreed upon surgery is if we're dealing with someone with a very large lesion with brainstem compression and or neurologic deficits. We're going to the next slide. So this of course is a presumed vestibular schwannoma. Of course, the other term for this, which should be going out of use, is an acoustic neuroma. And typically for these, as was reflected by the poll answers by our residents, you avoid a biopsy. This is something that is treated based on clinical and radiologic diagnoses. There is a Coues grading system, which basically classifies these lesions from 1 to 4 for the residents. If you're looking at a lesion that's completely intracanalicular, well, that would be a grade 1. If it's going into the cerebellopontine angle, that'd be a grade 2. If it's starting to touch, or it basically fill the CPA and start to touch the brainstem, but without displacement or disfigurement or mass effect, frank mass effect, then that'd be grade 3. And then a grade 4, that's a typo, that's not 6, that should be 4, is a grade lesion that is causing basically brainstem or cranial nerve displacement. So in this case, this was a patient who was treated using the Gamma Knife, so single fraction SRS to 12 gray. If this patient instead were being treated with a 5 fraction approach, what would be your choice for dose? And after we get the answers, I'd love to hear from the panelists, how they approach the dosing considerations at their institutes.
Yeah, while we're talking, actually, Emma pointed out there where we're waiting for the answers. It looks like somebody did point out or ask what's the best answer for boards in terms of that anaplastic astrocytoma. I think probably the best answer is probably temozolomide with the current data. So I think that's safe to say on boards.
Yeah.
I would agree.
Agree.
Okay. Perfect. And so that would be often considered, if you're treating these in 5 fractions, then oftentimes 25 gray and 5 is what people would turn to. 30 and 5 and 35 and 5 are generally doses that one would use for more malignant processes. And 15 and 5 would arguably be too low for either possibility. We'd love to hear from Jonah and Jerry about how you typically treat, let's say, a not super large vestibular schwannoma.
Yeah, I think this is a really interesting question. I think your point, Sean, about having we don't do Gamma Knife. And so, our radiosurgery approach doesn't involve really a neurosurgeon placing a frame or coming and doing anything in terms of billing. We tend to do more hypofractionating, like a 5 fraction or sometimes a 3 fraction setting, kind of looking at like the Stanford CyberKnife data and things like that. Tend to normally do, and I think especially with COVID, and we have a lot of patients who live far away. You know, I used to think, and I was trained that fractionation was the best way to go in terms of hearing preservation. But I think in terms of, you know, the data coming out now that fractionated SRS, or, you know, a 5 fraction, or even a 3 fraction or single fraction approach is pretty good in terms of facial nerve preservation and low risk of toxicity, and, you know, reasonable hearing preservation rates too. We would do something similar to what the attendees voted for, probably a 5 fraction.
And for me, it's the same. I came from a Gamma Knife institution for my first faculty position. We actually did higher doses of 5 fractions there, even though we had Gamma Knife, and we saw large rates of radionecrosis, which is another interesting finding. Much like pituitary adenoma, there seems to be a higher risk of radionecrosis for these. But for the COOS-3, which we call lovingly kissing brainstem, those we tend to just be concerned about any additional risk of swelling. So I tend to do 3 to 5 fractions for those. And we do get our otolaryngologists and neurosurgeons involved just to make sure that they're engaged. But we found that more and more over the last 3 to 5 years, that 3 to 5 fracture regimens.
Have either of you, let's say within the past couple of years, approached a patient with a large vestibular trauma with a fully fractionated approach?
I actually have a case who just refused surgery. He just didn't want surgery. I did a fractionated approach. He had a lot of swelling after, and then like it actually got a lot smaller. So I think for big ones, I still tend to fractionate. You know, I'm pretty conservative in that approach, but I think for the one that you're presenting here, Sean, I think it's, you know, really reasonable to do radiosurgery.
Yep, and I just wanted to bring that up as a point to the residents that, you know, that oftentimes all you'll hear about is radiosurgery or high fraction approach, hypofraction approach, but there's so much good historical data showing that 45 to 50 gray, you know, yields to really good long-term tumor control. And, you know, although I'd say with better technology, with the capability to easily do 5 fractions on something like the Gamma Knife, we've moved away from doing that. But I have also, within the past 2 years, treated someone with a giant, giant lesion who could not be treated surgically with a fully fractionated approach. And so that's also a valid option. I just wanted to make sure for the residents that even though we haven't discussed that as an option, that's still a good option. If we could go back just one slide now, this was
we're over time.
Oh, I got you.
1 o'clock. For time purposes, we have to wrap it up. This has been a wonderful discussion. Now, will you go?
If I could just make one quick point.
Sure,
basically, the last slide was was referring to transient enlargement, which can oftentimes happen with these lesions. And if that happens, if let's say 6 months post radiation, if the lesion expands a little bit, these lesions behave that way, you know, very typically. So that does not mean that they're progressing necessarily. Just have to watch them. And then finally, this is just a very quick example. I'm not going to spend more than 30 seconds on this, but this is a patient who had a large, much larger lesion that we treated 25 fractions, who could not get surgery, could not lie down, so we couldn't do a fully fractionated approach. And that is also a very good approach for larger lesions, as you can see, had a very good response. I'll stop it there.
Thank you to everyone. I know that there's still some questions, but you can always reach out to any of our panelists. Please make sure to fill out the post survey. It helps us improve these sessions and improve Rover 2.0. You can always go to our website, radoncvirtual.com, or contact any of us. And next month, we will have, on January 8th, will be pediatrics with Dr. Lucas, Terazakis, and Kumar. Thank you to everyone.
Thanks for the invitation. I'm happy to hear from anyone. If you have any questions, please feel free to email me directly and keep the conversation going.
Thanks, everyone. I'm happy to take any questions from email. It was really nice chatting with you guys.
Same. Thanks, everyone. Have a great weekend.
Thank you.
Thanks, everyone. That was so good. Nice to virtually meet you. Bye.
Thank you.